So on behalf of the Minnesota Oral Health Coalition and our partner, Minnesota Public Health Association, I just want to welcome Dr. Eileen Crespo and Matt Flory, and thank you so much for presenting today. And I'll take it away.
Dr. Crespo, I have the first slide up for you, the HPV as cancer prevention. Just let me know when you want me to advance it.
Oh, great. Okay. So good afternoon. My name is Eileen Crespo. I'm a pediatrician at Hennepin Healthcare, but I also work as the Vice President of Medical Services at Delta Dental of Minnesota. I am very excited that Nancy has asked Matt and I to present today. This is a topic that is near and dear to my heart as a pediatrician, trying to get kids vaccinated against a very important virus. I want to begin by letting you know this talk will not include the coronavirus. I know that that's what everyone is talking about. This is going to be a, I don't know, hopefully a much needed just break from the inundation of information about coronavirus, but something that is very important that oral health providers and people interested in public health can really enhance our efforts to increase vaccination rates. So we're starting with that first slide because really that's the message of today, that we need to kind of change the focus of HPV vaccine for people to really understand that it's cancer prevention. We're going to talk a little bit about kind of the fits and starts that have affected the rollout of the HPV vaccine in the United States and why it's so important to increase rates. So with that, we can go to number 2, or the next slide, sorry. Okay, so hopefully you're looking at slide number 3, which is basically letting you know that HPV infection is very common. 4 out of 5 people will become infected in their lifetime. So it's not so rare, and because it is so common, that is why it's so important to vaccinate all people, but specifically children and adolescents at the youngest age before they're exposed to any of the HPV types. We know in the United States, less than 50% of adolescents are completely protected by the HPV vaccine, although their vaccination rates for other routine vaccinations of childhood and adolescents are close to 90%. So we've really missed the opportunity that HPV vaccination presents us to prevent cancer in the next generation. According to estimates, if we could vaccinate all eligible adolescents, we could prevent nearly 30,000 cases of cancer caused by HPV. Next slide. Oops, let me advance my slide. Okay, so this is just a map of the United States. This is a 2018 data showing the rates in each state, and what you might notice just as an overall look is that vaccination rates are better on both of the coasts, on the West Coast and East Coast. The East Coast has some real champions, and I'll highlight Rhode Island, that has nearly 90% vaccination rates for their adolescents, and they've been able to do that because they require HPV vaccination for school attendance, which is one of the most effective ways to get vaccination rates up. Minnesota is there in the middle. You can see that it is shaded to the 40 to 49% overall vaccination rate. So we are in that, less than half of the population who are eligible for vaccination are vaccinated in this state. So we really do need all hands on deck to try to improve these rates. The next slide is really the evolution of the HPV vaccine. I find this, I don't know if it's just the nerdy part of me, but I think it's really important to know why HPV vaccine has been so poorly adapted here. And so we'll start at the beginning. So in 2006, the FDA approved Gardasil, the 4-valent vaccine. That was the original vaccination that was approved here, and it included HPV types 16, 18, 6, and 11, and it was initially rolled out for females only. It took a number of years before the FDA and all interested parties understood that females are likely getting infected from their male partners, and so we need to vaccinate males as well. And so in 2009, they expanded the recommendations to include males to be vaccinated for HPV, and this to this day continues to be a question that I hear from parents from time to time saying, isn't that vaccine only for girls? Isn't it just for cervical cancer? So why would boys need vaccination? So I still need to explain a little bit to parents why males overall should be vaccinated against HPV. So the recommendation is to vaccinate all children starting as young as age 9 up to 26. So we'll talk a little bit more about that in the upcoming slides. But moving along these boxes here, in 2009, the FDA approved a vaccine that only covered HPV types 16 and 18. Those are the predominant vaccine types that are oncogenic or cancer-causing. But that vaccine was short-lived because in 2014, Gardasil expanded to have 9-valent vaccine, and that means they added 9 types of the HPV virus. So to be very specific, 16 and 18 are the most common HPV types associated with cancer production. HPV type 6 and 11 are implicated with genital warts. And then the other 5 vaccine types that you see there, 31, 33, 45, 52, and 58, are thought to be responsible for about 10% of HPV cancers. And so those were added into that vaccine. And that vaccine is the only vaccine available for use in the United States today. That's all we use. And that's what we are giving to all of our adolescents. Initially, there were 3 doses recommended for all adolescents as we vaccinated them. But in late 2016, after a number of research studies showed that 2 doses were as effective, the recommendations changed. And so for children or adolescents under 15 years of age, when they are beginning the vaccination series, they only need 2 doses to be protected. On their 15th birthday or afterward, they need 3 doses. In 2018, you may have seen that the FDA approved HPV vaccine for 27 to 45-year-olds. This is just a recommendation. This is something that we encourage adults to discuss with their providers. It's often not covered by insurance, so that has limited the adoption of vaccination in older adults, well, not in young adults really, because they're 27 to 45. So that's really a source still of controversy and really a discussion between people who perhaps weren't vaccinated when they were younger and their providers. But overall, you should be aware that greater than 270 million doses of HPV vaccine have been given overall. On the next slide, this is just a little bit more detail of those HPV vaccine types. So if you look at the dark blue bars, the darker blue bars, those are HPV types 16 and 18. And then below the top bar shows you the cancers that are associated with those HPV subtypes. So you'll see cervical cancer for women, the overwhelming largest group affected by those HPV types. And then down on the bottom of that slide, you see oropharyngeal cancer, which is why we're having this discussion today, which is more common in men, and again, predominantly caused by those HPV types 16 and 18. If you move over just a little bit to the right, you'll see that lighter blue bar that includes those additional 5 HPV types that I said were added to the Gardasil 9 vaccine. Those are thought to be responsible for about 10% of HPV-associated cancers. On that slide, though, you will see the other types of cancers associated with HPV, which are a variety of genital cancers, including cancer of the vagina, the vulva, the anus, the rectum, and male genital cancers as well. So these are wide-ranging cancers that affect, obviously, males and females. So we can go to the next slide. This is a schematic of how the human papilloma virus infection progresses to cancer. So on this slide, I'm just going to make it a little bit bigger on my screen so I can see it better there. Okay, so on the left-hand side, you'll see the normal cervical cells. So this is using a cervical cancer model, but so they're normal cells of the cervix. And then the purple circles are the infective particles of the HPV virus. And then that basically takes over the cell machinery, duplicating its DNA, and then spreading to other cells. And as you see, as the as that slide goes to the right, the duplication, the replication continues significantly and will go through the basement membrane, and that's how cervical cancer can spread to other parts of the body. I want you to also focus on the circle on the bottom half of the slide that has the genes of the HPV virus, and just focusing on L1, if you can see there, that is what has been used as the focus of HPV vaccination. So the HPV vaccine targets that L1 protein for antibody production. So if you see the next slide, this is a picture of the Gardasil 9 box. And if you look along the bottom line of the type, it will show you that it is focused towards those HPV types. It lists all of them right there that we've already talked about. Those are the 9 types. And this vaccine is directed at the L1 proteins, just so you know that's how that vaccine works. And then your body then makes antibodies against those proteins, those viral proteins. So if we go to the next slide, this is the Iceberg model of HPV. And this just goes to certain factions who have said vaccination is not necessary because we can do screening for cancer. And what we know is that cervical cancer is the only one of the cancers caused by HPV that has a pretty well thought out screening process, and that is usually pap smears that women have been getting for decades. And with that kind of screening, you can find some cases of overt cancer and pre-cancer, but as we know, not everyone is able to have adequate health care, not just in the United States, but around the world. So that screening for cervical cancer isn't the best. It's the only thing we had until HPV vaccination. And because HPV causes all the other the other cancers that we've talked about, that you see on the bottom of the kind of the underwater part of this iceberg, the penile cancers, vulvar cancers, there are no screening for those types of cancers. And so prevention is always better than screening. And we know that greater than 90% of the HPV cancers can be prevented with vaccination. So the next slide reviews the studies that have been done to change the vaccine recommendation from 3 doses to 2 doses. This is a very busy slide, and without a pointer, I apologize. All I want you to do is just glance at the these are antibody levels, and you will just see that for girls who are vaccinated between ages 9 to 13 compared to the women vaccinated between 16 to 26 years of age, just how much higher the antibody levels are. That's really just the only thing you need to be looking at. And just you can see that 2 doses and 3 doses is about the same. The antibody response is somewhat equivalent and just so much better than it is in the older population here. And so all of this just means that those the younger we can vaccinate, girls and boys, obviously, we can get better antibody levels that can persist. So this is just the rationale for the change of the dosing. The next slide is some of the reasons why we've not been able to really get vaccine rates as high as we would like them to be. And this is because we vaccinate kids who need their parents' consent. And if parents are not willing to give that consent because of these reasons, we need to work on those to try to increase rates. So you can see here, nearly 20% of parents thought that the vaccine was not necessary. 14% felt that their provider didn't recommend it. 13% had concerns about safety. 12% felt like they didn't understand what diseases were caused by HPV, so they didn't feel like their child needed that. And 10% felt that because their child wasn't sexually active, they didn't need the vaccine. So the next few slides are kind of addressing some of those concerns. The myth versus the reality of safety concerns is something I think is important for people to understand. The first part, let me see. Okay, yep, the first thing that should be, I'm sorry, Matt, if you advance, if you're showing the slide, if you advance one time, you get one. Okay, so you just get that first line.
Yep.
So we just want people to understand the HPV vaccine is no longer new. I mean, if you think back to what I showed you, it's been approved in the United States since 2006, so we've had nearly well, we've had 14 years of experience with this vaccine, so it's not new anymore. And I will still hear parents say, well, that's a new vaccine and I don't think we know enough about it. We know a lot about this vaccine and we've used it and it's been used around the world for at least 15 years. So we actually do have a lot of information about HPV and the safety profile. If you hit the slide again, you'll see the next fact there, which is that parents need to know that the HPV vaccine has risks similar to all vaccines. And that means that nearly 80% will complain of pain at the injection site. If any of you have been vaccinated recently, some people really perceive the pain of injections to be significant. I'm one of them. I'm pretty wimpy, and even getting my yearly flu vaccine, it hurts me, but I do it. It's important. So just to let kids know, I mean, it's not painless, but it is the typical pain that anybody would experience with a vaccination. 17% of families and people who are vaccinated will complain of bruising or discoloration at the site. That's just some redness when the vaccine is administered. And then that 10 to 15% who report syncope or near syncope. What we want everyone to understand is that syncope and near syncope, and what that means is either passing out or feeling like you're going to pass out or becoming faint or dizzy are very common responses to anything involving a needle. So vaccinations, having blood drawn, these are things I've seen over my entire career. I've had kids try to pass out after getting a tuberculosis test. Syncope or kind of that disease sensation is something that's very common. And we want parents to understand that, again, these are risks with all vaccines, not just HPV. Again, if you advance the slide, you'll see the next little fact there, again, that 270 million doses have been given. So again, we have a lot of experience. And if you advance the slide one more time, you see that no serious adverse events have been reported with HPV. And I'll go into a little more detail on the next slides. So we should be on slide 13, Matt, is that where you are?
Yep.
Okay, all right, so these are studies that have been done that looked at pre-specified outcomes. That is, there have been reports and rumors and myths about a variety of conditions associated with HPV vaccine. You see them listed here on the right-hand side, including Guillain-Barré syndrome, stroke, appendicitis, seizure, allergic reactions, anaphylaxis, syncope, as we've just discussed, and venous thromboembolism. These are technical medical terms, but let's take appendicitis as an example. There were reports that having an HPV vaccine increased the risk of appendicitis. We liken it to, you are at the doctor, you get a vaccine, you leave the doctor's office, you get hit by a bus. Are those two things related? Probably not, but the FDA looks very seriously into these reports, and so they did. If you go to the next slide, this is just a review study that basically looked at 9 studies over 500,000 subjects, greater than 1 million doses of vaccine, and the only association they could find that was borne out in the data was syncope and skin infection. And for the purposes of this discussion and this scientific study, skin infection was any redness that was counted as skin infection. So those are the things that we need to let parents know, that yes, there is a risk of syncope and skin infection, but those are almost always mild. I have seen kids get woozy certainly after blood draws and after vaccines. And what we recommend now is that teenagers remain seated for 15 minutes after the HPV vaccine, and they do fine. If we advance to the next slide, this is the current HPV vaccine schedule and dosing. And you see that there's a wide range of ages there. So again, starting early, that is ages 9 to 10. Those children only need 2 doses of this vaccine. And again, we can give it as young as age 9. And I will tell you frankly, we have started shifting to really vaccinating 9 and 10-year-olds because if we do that, then we can use their 7th grade required physical, which in the state of Minnesota, kids need to have a physical or a doctor visit at about age 11, 12. And when we were using 11 and 12 as the vaccination start for HPV, we oftentimes don't get those kids back. They don't come back until they're maybe 16 or 17 or not at all. Excuse me. But if we start early and we're using that 9 or 10-year visit to start the vaccination, we can get that second dose by 11 or 12, and then they're done. So the kind of shift of the thinking is starting early, getting the last dose in at 11, 12, and then considering ages 13 and 14 to already be late, although they still only need 2 doses. And then again, really late is over 15, which is they need 3 doses. We can go to the next slide. This is what I excuse me, previously alluded to, which is the FDA-approved HPV vaccine for people aged 27 to 45. But this is something that we recommend that people discuss with their primary care providers whether they would benefit from vaccine at that age. The next slide should be slide number 17. And this is a fantastic, really public health achievement that has occurred in Australia. It just so happens that one of the co-creators of the HPV vaccine is Australian, and he's in that photo. But basically, they started a vigorous vaccine program in Australia starting in 2007. They vaccinated males and females as soon as the program began there. They provided it free to their population, and they were able to achieve over 90% vaccine uptake there. And because of that excellent work that they've done, according to their calculations, by 2028, less than 4 women per 100,000 will be diagnosed with cervical cancer. And by 2066, less than 1 woman per 100,000 per year will be diagnosed with cervical cancer. So that is just an amazing triumph of public health. And that's something that I think we should all be jealous of and try to model elsewhere. If you go to the next slide, this is the kind of the involvement of the American Dental Association, so that in 2018, they adopted a policy supporting HPV vaccine and encouraging dental providers and dental professionals in all ways to basically join the cause and try to help prevent infections that cause oropharyngeal cancer. So this is kind of where what we're talking about today. The American Dental Association saw that dentists can be really part of the primary care network and can be and should be addressing more things than just your teeth. And we know that dentists have been active in things like smoking cessation. They do some screening for domestic violence. They can do some questioning on health histories and medications. So really trying to use that medical dental integration model that they could be part of the solution for increasing HPV vaccine rates. If you go to the next slide, these are some materials. So different organizations have tried to fill the void of materials for dentists to have some more information about how they could counsel their patients. So this is from the American Academy of Pediatrics. And it basically gives some really nicely worded and basic information for dentists if they have questions about HPV vaccine. And that's available to download for free. And the next slide, which is a material created by the CDC, has very specific talking points about the most common questions that parents have about the HPV vaccine. So that if you as a dental provider were talking about HPV vaccine, asking whether their adolescent has been vaccinated, and parents said, well, I don't know about that, why do they need it at such a young age? This handout specifically has the information that you could be providing, which is hopefully some of what you've learned in the slides that we've reviewed today. This is also available for free. You can download it from the CDC website, and the link is on the bottom of that, of the picture of that slide there. The next slide is really, I think, a really fascinating way to think about it, which is in Oregon, dentists have added vaccination to their scope of practice with the goal of including HPV vaccine in the dental office. This was just passed just about a year ago. And so Oregon, I think, is going to be a model because they're working out the kinks of kind of how can we actually do this and put this into place. How do we store vaccine? How do we administer vaccine? How do we document vaccination so that if they see a medical provider 6 months after, they can get that next dose? I keep your eye on Oregon, and we'll see what they come up with as they try to roll this out. The next slide is a little bit of the rationale as to why dentists are in the perfect position to aid to increase HPV vaccination rates, is that young people are in dental offices. We know that 3/4 of Minnesota adults age 18 and older have had at least one dental visit. If you remember the age that vaccination is recommended from 9 to 26, dentists could be kind of filling that void for those older adolescents who perhaps didn't get their second dose or perhaps didn't even start the series. So there's a great opportunity there. We know that about 50% of 10 to 14-year-olds had at least one dental visit in 2015, and that, oh, okay. Excuse me, I have a text that there's a question. Nancy, do you want to send me the question right now, or I have 2 more slides and I'll be done. I'm going to try to continue. You send me the question and I'll answer it in 2 slides. But so,
okay,
so on the same slide, so 40% of children ages, well, teenagers ages 15 to 19 had at least one dental visit, and again, could be in that prime catch-up age range. The next slide is the comparison to medical visits, and this is the Minnesota data, basically showing that we really lose a lot of these kids in the adolescent age group when most kids are doing, they're doing pretty well, they're mostly healthy. A lot of the diseases of childhood, ear infections and the like, and strep throat are less, and so kids aren't always in our offices. And the dentists really have a great opportunity in these age groups to either start vaccination and or finish it if they've gotten that first dose. So the last slide here for my part is, I think, really pertinent to the day and age we're living in. I think if that said, if there were a vaccine against coronavirus, wouldn't you get it for your kids? I think most people today would say absolutely. But this goes to the same thinking. If there was a vaccine against cancer, wouldn't you get it for your kids? This is just kind of just what seems to me to really be common sense. If there's something we can be doing to prevent cancer in the next generation, and it's available and it's safe, why can't we do it better? So that was the focus of this talk. I hope that was helpful. And with that, I'm going to turn it over to Matt. Nancy,
do you want to take those questions now, Dr. Crespo, or do you want to do them at the end? It's fine with me.
I can. Okay. If Nancy wants to send them to me, I don't have them, and I can't see the chat.
Yeah.
Yeah.
Dr. Delator had a question. Do you want to? Can you ask it, or do you want me to? I don't know if you can.
Everyone.
I'm sorry. It's not Adele. Sorry, I thought it was Adele Delator. Sorry.
Oh, no worries. I just had seen the first resource that you were referring to, and I didn't quite catch where you could find that for HPV flyer or the brochure, the one before the CDC one that you had posted on one of the slides.
American Academy of Pediatrics.
Okay.
Yeah.
American Academy of Pediatrics.
The link is okay. I'm sorry to talk over you. I apologize. This is a resource from the American Academy of Pediatrics, and if you put in American Academy of Pediatrics, you are the key. This resource should come up for you, and it has at the bottom of that sheet, it has if you need more information, it has the website there. So if you should be able to see it a little bit bigger. And I think Nancy is going to be sending out the presentation. If you missed that slide, it will be available. It's right on the slide on the bottom.
Great.
Yeah,
right, Nancy?
Yeah.
Yeah.
After we're done, probably today or tomorrow, on our resources page on the Minnesota Oral Health Coalition website, we have a link to a Dropbox, and it's going to contain all this information. And if I can, I'll just get the links and I'll put them on a piece of paper. Put them on a document. You could just click on that. So yeah, I'll have a file in there with this PowerPoint and the recordings, and then anything else I can pull up from the presentation.
Okay, if you like, while Matt is doing his part, I will get those the links, and I can send them to you, Nancy, and you can post them on the chat box if people want to copy them down.
Oh, I love that. Thank you.
Okay, so without further ado, I'm going to turn it over to Matt from the American Cancer Society, and Matt is going to talk about Minnesota-specific issues. So go ahead, Matt.
Thank you, and thanks everybody for joining us today. So what I'm going to do is try to transition this and talk about, Dr. Crespo, I think, laid a great foundation about the general background, not just the general background, but the background for why this is important. I want to make the case, not to you, but help you make the case to people to understand that this isn't just something that happens in the United States, but something that's relevant for locally. And I like to use the analogy of Lake Wobegon because Garrison Keillor used to say it was the place where everybody was above average. And that's the way people think. Minnesota is actually way below average. If you remember back, and I won't play with the slides, but that national map, Dr. Crespo called out the East and the West Coast for being ahead of us. Guess what? So are a lot of our surrounding states. And we're used to maybe Wisconsin being competitive with Minnesota, but North Dakota's beating Minnesota. Iowa's beating Minnesota. Nebraska's beating Minnesota. We're way behind. We are not above average in Minnesota. And the whole country needs to work on HPV vaccination, but Minnesota in particular. Probably not because we've done a bad job in vaccination, so much as a better job in other areas, but this really has not been as big a focus for our clinicians as maybe it could be, or as it has been in states like Rhode Island. So there's really an opportunity, I think, for us to get other stakeholders on board to help clinics that may be extended or overextended, prioritizing other things, and help us get this message out. I'm going to show you again some local data. This is state data from the state of Minnesota. You don't have to understand complicated math to see that you want to keep that trend line going down. These are all of those HPV cancers that Dr. Crespo mentioned combined. And they were going down through about 1999, and then they took a sharp shift and started going up. These HPV associated cancers, these are the rates in Minnesota, not the rates nationally. And a big part of that increase is actually oropharyngeal cancers, cancers of the mouth and pharynx. So, basically head and throat cancers. What you would hear if you were talking to some family physicians, and the Minnesota Department of Health, was telling us this. They had some staff going out to meet with family physicians, especially in rural Minnesota, that said, well, don't you think a lot of these oropharyngeal cancers are related to smoking? And they were about a decade or so ago. And as smoking rates went down, the oropharyngeal cancers started to go down, but they've started to go up again. And based on testing, I've talked to a number of medical directors who happen to be oncologists who say, what people don't realize is the oropharyngeal cancers that are coming are now not as likely to be tobacco related as HPV related. And this particular graph is just in men. So when we're speaking about men and women, what's important for people to understand is we're not just talking about cancers that can affect men as well as women, but some of these cancers, oropharyngeal cancers in particular, are affecting way more men than women. So it's not that men equally need the shot. In some cases, men might need it even more than women. The Minnesota Department has a great a great video testimonial that they recorded last year. We put them out on Facebook and on Twitter. A number of partners like the Cancer Society also retweeted them. You can find the link in the slides, or you can email me afterwards. But this is a story of an oral cancer that was HPV associated. It's a little vignette of Steve. I particularly like this one because in 2 or 3 minutes, we don't just get Steve's story, but in the backdrop, you can see what are easily recognizable as Minnesota locations. So it's not just a good general story or a story that's got the Minnesota Department of Health logo in the corner, but it's clear that this is something that happens in our state, not just something that happens somewhere. This is actual data from our Minnesota immunization information connection, so the MIC registry. And what I want to do first is point out the HPV initiation. This is data for those 11 and 12-year-olds that are coming in for visits. Those first 2 columns are vaccinations for Tdap and meningococcal. The third column is the first shot for HPV. Everybody that was getting Tdap and meningococcal was in the office to get those 2 shots. The difference between the first 2 columns, the first 2 columns and the third one, is who got 2 of the 3 shots. So there's a missed opportunity already at age 13, or at 11 and 12. Now that doesn't mean we at the Cancer Society wouldn't like people getting shots earlier. As a father of a 9-year-old, I was looking forward to my daughter getting that shot at this well check. And we may put that off a little while because of the coronavirus, but that's certainly a question I'm going to be asking our pediatrician, and fairly confident that that they'll be getting it, because this is a practice that many pediatricians are on top of, but maybe not as many parents. What you'll see over there in completion is we did from 2018 to 2019 have some modest progress, But by age 13, which is the current recommendation, only 1 in 4 Minnesotans are really up to date by age 13. Now, other people are getting it, preteens are getting it 14, 15, 16, 17. So it's closer to 50%, but they're getting it later. And if you remember Dr. Crespo's point, later vaccination is less effective. And parents are putting it off for what they think is a very good reason. If my kid's not going to have sex, then they don't need the shot until they're going to have sex. What they're missing is the opportunity to get a strong immune response, more antibodies. And the way I explain this to people who ask me questions is that living in Minnesota, I tested my house for radon, and my house tested at an unsafe level. Now, I work at the Cancer Society, so I understand that the lung cancer risk is long-term. It's about, it's not about a year of exposure or 2 years of exposure, it's about decades. But I didn't wait a year or two to mitigate the radon in my house. I did it as soon as possible because I want to give myself, my children, and my whole family as much protection as possible. So what I try to say to people is, I know you're saying from a comfort standpoint, you want to hold off, but why wouldn't you give your kids the shot when it's going to give them the strongest immune response, the strongest protection? Why would you put it off from your comfort and sacrifice? 80% protection is great, but why not 90%? Why would you let it drop to 50% or less than that? The longer that your children put off this shot, the less of an immune response they would have. It has nothing to do with behavior. So I absolutely agree with Dr. Crespo. We should not be talking about sexuality. We should be talking about immune response, and that the opportunity to vaccinate children earlier, and to say this is not just a problem somewhere. This is a problem in Minnesota, and it is pretty consistent across the state. But we have some of the best data in the country because so many providers provide it, where our immunization registry is frankly the envy of a lot of other states. But this is also a state with a lot of data transparency. So this graph is on the Minnesota Department of Health website, but I'll tell you the Data Health portal actually has a mouse over so you can find county level data. And I'm just going to show you one county in particular. This is Murray County. You can actually see at the county level what the vaccination rates are for these different shots. HPV initiation is the first shot by age 13. So in Murray County, they're doing pretty good with that first shot at 64%. But exactly to Dr. Crespo's point, getting students back for the second visit is very difficult. 22%. So again, less than 1 in 4 students in Murray County are up to date. We can pull this for any of the counties in the state. So you can say, well, it's not just Hennepin County we're going to pick on. Well, it's not just rural Minnesota. What is it at in our county? And that is not key to understand the importance of it in general, but actually helping other stakeholders in your community, other parents understand this is not a Minneapolis problem. This is not a Brainerd problem. This is a problem in our community, in our area. There are many opportunities for vaccine champions, which we would include dental health professionals in. We're looking for people to reach out to other people in your office, in your practice. If you're in a dental practice that's either a part of a health system that has clinics and primary care groups, or you just happen to know people in town, we're looking for that provider engagement directly. There are still some physicians who are not quite as comfortable recommending this at the same level we'd like the CDC. And we feel at the Cancer Society that in addition to hearing from organizations like ours, it's good for providers to hear from peers. There's patient and public engagement opportunities. And for patients, that reinforcement from the dentist, whether you're giving the vaccine directly or just encouraging people to talk it through with their doctor is great. There may also be public engagement opportunities to do things that are facing, outward facing outside of your practice in the public realm. And in particular, we're going to start doing this year more in terms of earned media, things like letters to the editor. So if anybody on this call would be interested in potentially signing that, especially to the smaller local papers, whether those are suburban newspapers or rural newspapers, they may not always have the circulation of the Star Tribune, but it's much easier to get them in there. And I will tell folks that in my suburb of St. Louis Park, a lot more people read letters to the editor than I would have ever imagined. Having submitted some myself, I'm shocked at how often people tell me they read the letter that I submitted. So much easier to get something into the Sun Sailor in St. Louis Park than it is in the Star Tribune. Social media, also an important and easy way to do it, especially if you use hashtags that help people see it beyond the people that are in your group. And we'll be rolling out a lot of new messaging this June. Traditionally, the volunteers and partners the American Cancer Society works with are people in primary care or in oncology. They're not necessarily people in dental health. So if there are opportunities that we could work together, we'd certainly be open to that. Dr. Crespo referenced earlier the HPV Vaccination Roundtable. This is a national coalition funded by the CDC, and it's a partnership coordinated between the American Cancer Society and the CDC, but it has hundreds of organizations, including the American Dental Association. They have a great resource here, which an action guide for dental health providers. And that action guide includes action steps. I'll show people briefly, less important to try to read the small text, but the highlighted blue are actually hyperlinks. And so I like this document in particular electronically because you can click through exactly to them. There are also some resources that are really helpful, including a really deep footnoted bibliography, which again has links you can click through. In addition, lots of these resources from many organizations, including not just the Cancer Society and the CDC, but also the American Dental Association, can be found on the HPV Roundtable website. The HPV Roundtable is launching a campaign this spring. They're hoping to kick it off a little bit more formally in June, but they've already started doing some webinars called We're in 2020. This was envisioned or imagined as a campaign for primary care providers, and we do have some local health systems that have joined, but we have also had other stakeholders sign on to make sure they're on the email list. So if you're interested in this, you might look into it. I'll give you an example. If Carver County Public Health can sign on to this, certainly dental health practices or dental health professionals would be encouraged to do it as well. So it's just another way that we can try to create some linkage between different medical groups that are interested in encouraging vaccination. The American Cancer Society has lots of resources for parents and the general public. Pictured on this slide, you can see an infographic that we put together, slightly different version of a lot of the same concepts you saw in Dr. Crespo's presentation. In particular, this downsloping graph showing that cancer prevention actually decreases as children get older. On the bottom, you see a circling on time as age 11 and 12. That's the take a shot piece. We have another with some simple talking points about protecting our children from HPV vaccines. HPV Vaccination, Just the Facts is a document set up for providers that talks through some of the myths. Again, we're not really bullish about which version of these fact sheets or whose logo is on it. We just want to get the right information out. And you'll see again and again, very similar messaging because there is a lot of coordination with the CDC, the Cancer Society, the Dental Association, primary care folks at the national level. What we're really looking is for more efforts to make this a local version of that kind of collaboration. Again, I remembered, you may remember I talked a little bit about Steve's story. This is something that the Minnesota Department of Health put together last year in partnership with a couple other stakeholders to launch a public health messaging work group. And we hope to get back to that as a coalition sometime soon. But we do have, like I said, some existing local resources that could be shared. If anybody is active on Twitter or on Facebook, we share them through our professional accounts at the Cancer Society, but I regularly share these with my personal network just to get them out in circulation. I think it's good for more and more people to understand that, as Dr. Crespo noted, very few people understand that we're talking about 6 cancers here. They're mostly thinking about cervical cancer. They're mostly thinking about women. Steve's story helps us underscore that this also impacts oral cancers and also impacts men. And because of that upslope, that tremendous growth and oropharyngeal cancers in men, we think this is very important at the Cancer Society. Really interested in any ideas you may have, not just in terms of your willingness to do what we're thinking dental health professionals might do, but your ideas about how we might work together to get this story that this is a vaccine for men. It is a vaccine that impacts oral cancers as well, and that those oropharyngeal cancers are on the increase because of HPV that has not been vaccinated against. So here's an example quick. This is an example of the tweet from the Minnesota Department of Health. This is the actual hashtag. So if you wanted to go back and see what was retweeted in the past, you could. And these are all active. One of the great things I like about Twitter is it becomes a place where things are saved. So I actually pulled this up just earlier this week to make sure that put it in this slide. So it's got a slightly different picture. It's already pre-designed. So if you're not, you don't have a lot of time to write your own tweet and put something in there, you can just go back and find the Minnesota Health Department's version. So if you would like to get more involved, certainly feel free to contact me. That's my presentation for now. Happy to answer any questions or to defer to Dr. Crespo if there were other questions for her as well. Thanks, everyone.
I just want to thank you both so much. This isn't the first time that I've heard, especially Dr. Crespo speak, but every time I learned so much, and I had a list of questions to ask, and I just kept checking them off. I'm like, oh, she answered that. Matt? No, Matt answered that. So if anyone has questions, I'll just be quiet and be sure and speak up. And
Actually, Nancy, this is Eileen.
yes.
I wanted to just say one thing that I did forget in my presentation that I often get asked, I'll just say it now. The interval between doses, oftentimes people want to know, like, what is the interval? If they get one dose now, when are they supposed to get the next one? So I just wanted to just mention that if children are on the 2-dose regimen, if they're under 15 years of age, they get the vaccine, let's say it's day 0, and basically the second dose is 6 months from then. If they're on the 3-dose schedule because of age or underlying immune suppression, so kids who are on chemo and things like that, other reasons that they can't be vaccinated with the regular schedule. If they're doing the 3-dose regimen, it's 0, and then the second dose at 1 or 2 months. We try to get it at 2 months, and then the last dose at 6 months. So I just wanted, just in case anyone was wondering when it is they need that next dose.
Yeah, thank you.
Yeah, thank you.
Anyone have any questions? Oh, Eric, hi. This is from Eric Elmquist. Oh my gosh, one of the founding members of the MOHC. So Eric was wondering if there are any resources for parents who are unwilling to vaccinate due to religious reasons. Great question.
There are lots of resources if you use approved sites. So, excuse me. What I need to say is I usually try to tell my patients, like, don't just look on the internet, like look at specific accredited websites. So the American Academy of Pediatrics has a whole HPV toolkit that they can look in. It's really for providers, but it has lots of great information. The CDC has a lot of great information. For people who claim religious exemptions, this is something that I would like you to know, that the pediatric community overall is really trying to eliminate these personal belief exemptions because we feel that they endanger the health of all children. So I don't know that there's anything specific for people who have religious exemptions. There's great information for people who want up-to-date, scientifically accurate information. One of the best ones is, I have to look up his website. There's a pediatrician in Philadelphia, Dr. Paul Offit is one of the best. I'm just going to pull up his website. It's like immunization. Just a second, I'll pull it up. And I can tell you what that is. He's at the Children's Hospital of Philadelphia, and they have their own, let's see, Offit on vaccines. Let me see if I can pull up his all of his information. He's a great speaker.
And I'm happy to
why don't
include that in the Dropbox
okay.
for anybody.
I will find it and I'll send it to Nancy, and she'll put it up there. I'll find the address or the link.
It's a great question. Anybody else have anything? You can chat it, or you can just speak it out. Okay. Well, thank you both so much. Like I said, we're so fortunate that we have you two, and that you're willing to take time to do this for us. And I will have a link. We have, like I said, we have this Dropbox, and it'll have all that information in it. So if you give me about a day or so, You can look on our resources page on the minnesotaoralhealthcoalition.org website, and you'll have the video and the PowerPoint and some of these related materials and links. So with that,
Thanks so
I
much
think
for having us.
yeah. Sorry.
Oh, I was just saying, thanks so much for having us today.
Oh, thank you. All right. Well, everyone take care and be safe. And again, thanks to Dr. Crespo and Matt Flory.
Thank you.
Thanks, everybody.
Bye-bye.
Bye.